When we talk about vascular health and vascular disease, most people think about arteries. And when we talk about the circulatory system, you have arteries and veins. Arteries carry blood from the heart to the toes, and veins are what carry blood back from the toes up to the heart. More specifically, in the vein system, you have a deep and a superficial vein system. Your deep vein system is considered sacred. It's absolutely necessary. We don't like to touch it with intervention, and it's the one that we get concerned about when we talk about blood clots. You can get blood clots in both the deep and the superficial vein system, but the superficial vein system isn't as dangerous if you get a clot in that part of it. The deep system runs very close to the bone, and that's why we consider it a deep vein system. The superficial vein system, you can picture kind of like branches of a tree. It comes off of that deep vein system in particular areas, and it comes closer to the surface of the skin. So not only does it include the spider veins that you can see on the surface, or the big ropey ones that you can see as well, but it also exists in a plane of tissue that you can't necessarily see. And because you can't see it, people oftentimes mistake it for that deep vein system. But in fact, it is part of the superficial vein system. And when we talk further about vein insufficiency, more specifically, that's the area that we're targeting when we talk about interventions and things we can do to help make the legs feel better. So some important specifics about vein insufficiency. It does affect all age groups, and it's 10 times more prevalent than peripheral artery disease. I think the reason that it doesn't get talked about as often as peripheral artery disease is because it's not lethal. You have heart attacks, you can die. You have clots or blockages in the arterial system, and you can lose a limb. With venous insufficiency, it's not necessarily the case. Although it can progress and be risky, it's not as life-threatening as its partner in crime, the arterial system. But it is more prevalent than arterial disease. The cost is $150 million or $1 billion per year worldwide. So it is a very expensive healthcare concern, especially now in the United States when we're talking about healthcare exchange and that type of thing. The costs of hospitalization is very high with venous insufficiency because of the incidence of recurrent infection and wounds. This is a little more about prevalence of venous insufficiency. 30 million Americans suffer from it. Only 1.9 million seek treatment, and only 447,000 of those patients are actually treated. I think some of this has to do with the fact that the treatment for vein insufficiency used to be vein strippings. And anybody that remembers the old vein strippings, they were very barbaric, they were painful. People were hospitalized for up to 6 weeks because of the risk of blood clots. And so thankfully, in the last 10 to 15 years, technology has advanced dramatically. And we'll talk about those changes a little bit later on. So factors of vein insufficiency, the biggest and most prominent factor is genetics. Most people have a parent or grandparent that had bad veins, and it passes on down the line. The onset of vein insufficiency in women is usually about the age of 35, and in men it's a little bit older at 45. Things in women that can make it worse is pregnancies. We know with that increase in blood volume and hormonal shift, that increases the prevalence of vein insufficiency and kind of speeds up the time. The other thing that used to contribute to it was any type of hormone replacement. When we first started replacing hormones in women, we used to slam them with these big, huge doses of estrogen and progesterone. Those massive doses increased the incidence of vein insufficiency. It's not so prevalent now with the bioidentical hormones, and they've kind of dialed down birth control pills and that type of thing. So it's not as much of a factor, but it certainly used to be. Things such as smoking, hypertension, obesity, a lot of those we know contribute to vascular compromise. However, usually those attribute more to the arterial side of disease than the vein side. The venous anatomy we're just going to go through very quickly. These slides are very specific and get quite much more medical than we need to be. Again, we talked about the superficial and the deep vein system. This is an example of the greater saphenous vein. It comes from the foot on the inside of the leg and runs up along the shin onto the inside of the knee and then further up into the groin. That's the greater saphenous vein, and then you have a small saphenous vein which starts on the outside of the ankle and runs right through the middle of the calf and ends behind the knee. Remember, those aren't the only two superficial veins in the legs. They're like branches of a tree. So from those veins come all of the ones that we usually see on the surface of the skin. This is just an example of those branches of a tree. This is your greater saphenous vein here that you see, and these are two of the larger branches that come off in the thigh, and then you have several behind the leg and down into the calf as well. There's the small saphenous vein we were speaking of. It's this one just here. So very briefly, what causes vein insufficiency? Essentially, I like to equate it to stretching a rubber band out. You can stretch that rubber band out so many times, and then you can't make it regain its elasticity. That's very similar with veins. Because of gravity and the valves that exist within these veins, once they become weak and dilated, the veins always remain stretched out. And so for that reason, oftentimes we get the symptoms that we do. So if you're standing in a stationary position for a long period, or if you're sitting for a long period of time, such as on long flights and car drives, the blood kind of settles and pools in these weak veins, and that's what causes swelling, night cramps, fatigue, heaviness, restless leg, numbness and tingling. Some people progress into itching, recurrent infections of the legs, and then eventually wounds if it progresses to that point. This is one of the classifications that we use that are required to classify how significant veins are. So the reticular veins are the ones that you see on the surface of the skin, the little kind of red, wispy, almost spider vein-like eruptions. The varicose veins are the larger ones that almost look like little ropes or cords under the surface of the skin. Edema is just a fancy word for swelling. A lot of people get it around the ankles. If it gets real significant, then it just kind of builds and progresses up the leg. Pigmentation or eczema, a lot of times with vein insufficiency, when that blood settles and pools in these veins, the skin starts to lose the nutrients that it needs to stay healthy from the inside. So the body starts to try to protect itself. It starts to thicken and toughen up the skin, and then it can turn brown. And so if you are pale or fair-skinned, your skin turns a little bit more darker. If you're darker complected, oftentimes it will actually even turn black. So it just normally progresses, and then you wind up with lipodermatosclerosis, another fancy term, that the tissue starts to change and break down and cause ulcers. So let's get into treatments very quickly. Conservative therapies include exercise. The more active you are, the less discomfort you'll have in your legs in any vascular condition. If you have arterial disease, you're challenging those arteries to pump the blood further down into the toes so that you get better circulation. On the venous side of things, because these veins are weak and dilated and they actually exist outside of the muscle, you have to do everything you can to try to get that blood up to the heart. So being as active as possible is fantastic. So if you're sitting in a car for a long period of time and you can do those ankle rolls or the foot pumps, that helps a lot to encourage the blood to get back up to the heart. Any straight leg, if you don't have bad knees and you can do it, straighten out those legs and really flex those muscles, and it helps that blood to get back up to the heart, and it cuts your risk of developing a blood clot. Elevation of the legs helps. Anything above the heart, is usually the best. If you're sitting, with your feet propped up on a stool, you may not notice as much of a result as if you're laying with your feet a little bit elevated. Compression stockings, they're probably the bane of everybody's existence, especially in Phoenix when it's 115 degrees outside. Nobody wants to think about wrestling with compression stockings, let alone wearing them every day. But they do help because of that external support to help support these veins and improve that blood circulation back up to the heart. Sure.
I bought, because my husband stands a lot, and they have copper in them.
Mm-hmm.
Okay.
Copper, the jury's still out on copper and ions and how well they help the body with vascular circulation. My thought is if it doesn't hurt you, there's no harm in trying it. So if copper helps and it makes your legs feel better, makes you feel like you have a little more vim and vigor, then there's no harm in it. I wouldn't recommend eating the copper, but if you wear it externally, you're good to go. A lot of the athletic companies now are starting to produce compression stockings. Runners wear them, football players, baseball players, and actually it is just that compressive mechanism on the outside of the body that helps make the legs feel better. And they come in fun colors like that. So they do help. A couple misnomers about compression stockings: they do not prevent vein insufficiency from getting worse, and they do not keep you from developing additional abnormalities in the veins. So the only reason I recommend that you wear them is to help with swelling and to cut your risk of blood clots, especially with travel. So if you're going to be sitting in a car or on a plane for longer than 2 or 3 hours, you need to put those compression stockings on to help support the circulation and cut your risk of blood clots.
What about that compression stocking so tight around? I mean, you need
It cuts it off, yeah. And that's a good point. There is a happy medium. Most medical grade compression stockings you need to get measured and fitted for to eliminate that particular instance. Because if you just go to the grocery store and buy the medium because it says that's the size you should have, they can be extremely tight, particularly behind the knee, and that can be very painful. So that is a good point. An Una boot is a little more extensive. If you have wounds or something of that sort below the knee, then you can certainly utilize those to help with the swelling. The surgical stripping is what we talked about before. It is completely barbaric in my opinion. They actually use a crochet hook, for those of you who crochet, to actually go in and physically strip the vein out of the leg. What we found in the recent ultrasound data is that that actually causes more trauma to the branches of those veins that were stripped out, and so people develop accessory vein insufficiency at a much higher rate after they've had strippings. The thermal ablation has been out on the market for approximately 10 years now. There's 2 types of thermal ablation, and if you all are interested, I have a short video I can show you as to how it's done. But essentially the vein is accessed under ultrasound guidance just with a needle puncture. Almost like when you go to give blood or have your blood drawn, they puncture your vein with a needle. Well, instead of drawing your blood out, we actually insert that ablative technology into the vein that we're treating. With the thermal ablations, you have to surround those veins with numbing medicine because, as the name implies, it uses heat energy to close these veins off. And that's about the equivalent of 120 degrees Celsius, so not tolerable. Putting our hand on a stove is not recommended. So we surround these veins with numbing medicine, and then as we turn those fibers on, it actually closes those veins off from the inside. It's a great technology. There's no downtime or recovery with that treatment. We want you to be as active as possible afterwards and maybe take some anti-inflammatories, and then you're in a compression stocking for about 3 or 4 days after the treatment. Some people prefer to wear the compression stocking longer because honestly, that area is a little bit tender and sore for about 7 to 10 days. But after that 3 or 4 day time period, it's completely up to you as to whether you wear the compression stocking or not. So, very nice. There's a radiofrequency technology and a laser technology. They both are the same identical technique. The energy that closes off the vein is slightly different. We use both of these technologies in our office, and there's various reasons for why you would choose one over the other, but honestly the end result is identical. So they work very nicely. The newest technology, which I think is very cool, is called non-thermal, non-tumescent closure. And the reason it's called that is that you don't have to use heat energy to close the vein off, and tumescent is a fancy name for numbing medicine. So essentially what we do, and there's one company that makes it, and that's Medtronic. They kind of came up with these slides. God bless you. What you do is you access the vein under that same needle puncture with ultrasound guidance, but instead of closing the vein off from the inside with a heat technology, you actually use an adhesive to close these veins off from the inside. There was a neurosurgeon that was closing off malformations in the brain with the same adhesive, and he thought, hey, if I can inject this into the brain, why can't we close veins off with it? And so they changed the viscosity of this adhesive, and it works extremely well. After that procedure, you don't have to wear compression. The downtime is slightly less than the thermal ablation because there's not the same inflammatory response that goes along with that closure. So I think that's probably, in the long run, going to be the preferred technology. The downside with it now is that it's so new that insurance companies haven't come up with billing codes for it. So we can't bill insurance for it yet, but I'm hopeful in the next year or two that we'll be able to bill for that as well. The other plus with the adhesive closures is that you can treat several veins at the same time, whereas with the thermal ablation technology, you can only treat 2 veins at a time. So if you have multiple veins that are abnormal, that means multiple visits to the office, much more time intensive from a patient perspective, which is kind of a downer. With the adhesive closure, you can treat up to, very technically, 110 centimeters of vein at a time, which for most people gets both legs taken care of in the same day, which is great.
You anticipate that this is good, new technology is going to cost a lot more than the thermal?
I don't think so. The cost of the adhesive right now is pretty parallel to the thermal ablation closure. And now with as restrictive, or not restrictive, but with as conscientious as the insurance companies are about payment and reimbursement, I don't think it's going to cost any more. It actually, honestly, may cost less because you can treat more veins. You're not having to see people multiple times. Right. So I think in the long run, that one will be cheaper, which will be nice. The final one is the sclerotherapy. Sclerotherapy is a big blanket term for a solution that we inject into the veins that you can see on the surface of the skin. There's different doses of that same sclerosant, and there's different chemicals that you can use. It's the same as people used to call saline. It's not a saline solution. Actually, it's something called sodium tetradactyl, but because it has sodium in it, people equated it to salt, so then it started being called saline. It's not saline. It's actually considered a detergent. It's an irritant to the vein and actually closes the vein off from the inside. It's a very nice adjunct to these other technologies if you have larger underlying vein insufficiency. So if you've got the little wispy spider veins and you don't have any underlying issues, then you can use a sclerosant and it works very nicely. But if you have larger underlying vein disease, it's kind of like pulling leaves off a tree to trim it. They just grow right back because that pressure underneath is still there and it washes that solution right out of those veins, so it fails. So this is just an illustration of the thermal ablation. This is the laser technique. It is a direct beam laser and it is a continuous pullback method. And you deliver so much energy per centimeter to get successful closure of the vein, and that's based on a certain number of variables. So as long as you go to somebody who is knowledgeable in this technique, your results should be fantastic without any risk of complications. The radiofrequency closure, on the other hand, is a different type of thermal closure, and it actually closes within this 7 centimeter little coil. And so, instead of it being a direct beam laser, that is a segmental closure, so you actually close 7 centimeters, pull back a little bit, close another 7 centimeters, and do it that type. No pain. Remember, you're numb. And it doesn't take very long. It takes 10 seconds per segment. So if you're treating a whole leg, maybe it takes a minute and a half, 2 minutes at the most. For these types of procedures, it actually takes just longer to get you prepped and ready to go than it does to do the actual treatment. It's all this buildup, and then we say, okay, you're all finished. What? I'm done? It works very nicely. So this just briefly talks about the efficacy of the chemical or the thermal ablation closures. Honestly, they're very parallel between laser and thermal. We have about a 96% success rate. Honestly, I think ours is a little bit higher. I haven't seen an incidence of these veins reopening unless we have a gentleman that comes in and his veins are just massive and he doesn't behave himself and leave it to the guys to misbehave, then the vein has a higher risk of reopening. But I haven't had any women with this vein insufficiency having had one of these treatments and the veins reopen. So
you keep talking about closure, so there is no healing. You're closing everything.
Yes.
So, and the vein just stays in your body, closed, kind of dead, not doing anything. It doesn't.
Well, we close it off, and so with that closure, that's a great point. With that closure, what happens is the body pushes that blood to the healthy deep vein system, and that's what improves the symptoms and the visual appearance of the legs. So by closing off those superficial veins, you're actually improving circulation by getting that blood back up to the heart. The deep vein system is about 90-95% of the circulation back up to the heart, so that doesn't leave a whole lot with the superficial vein system. So in essence, you could close off, although it's not physically possible, the entire superficial vein system and be just fine from a circulatory perspective. So we try to base treatment off of symptoms and physical presentation. You don't want to go off closing veins that are normal and serving you a useful purpose. So, the gold standard for us with treatment for any of these types of therapies is an abnormal ultrasound. So, and
Just having all these closed veins in your body is okay.
well, your body actually recognizes this tissue as foreign once we close them off, and it very literally breaks that tissue down and carries it away and excretes it. So on ultrasound, after a year where you used to have a vein, you wouldn't see anything anymore. It just does not exist in the system anymore. Now with the adhesive closures, you're seeing them on ultrasound a little bit longer because that adhesive is considered foreign, so it takes the body a little bit longer to break those down, but the result is the same.
There won't be any new developments of collateral circulation or additional superficial veins coming off because these other ones are
Closed?
closed?
Good point. No. Yes, absolutely. The body doesn't grow new veins. But like any chronic progressive disease, you can develop additional veins that will become abnormal. We haven't seen that incidence with the thermal ablation like we did with the strippings. I think it has to do with the traumatic nature of the old strippings that caused more of the damage to the branches of those veins. With the thermal closure, we actually see no additional trauma to those branches. So, yeah, very good question. So these are some complication rates. Honestly, we don't see much of it. Bruising is the biggest one. If you bruise before the procedures, you will definitely bruise with the procedures. And honestly, we just recommend use of arnica. It comes in a gel, a tablet, a cream form, and it helps cut inflammation and bruising. Works very well. Even if you bump into something and bruise your arm, you just put a little arnica on there and it helps break down the bruise. It works very nicely. So I wanted to go over briefly how we diagnose vein insufficiency. Essentially, when you come in for an office visit, we ask you to fill out a screening form, and it's actually in those folders. And we like to evaluate what types of symptoms that you have when you come into the office, because oftentimes people have not just one type of vascular disease, but both. And so we like to evaluate for both arterial and venous disease when you come into the office. Arterial disease symptoms are very specific, and venous disease symptoms are very specific. And so if we can kind of tease out which bothers you the most and pair that with a thorough ultrasound, we can better tell you what treatment options you have and what's going to be best to help make your legs feel better. When we look at veins on ultrasound, we look at time. And we know anytime blood settles in pools, it causes increased risk of DVT or blood clots, because when we cut ourselves, our blood pools, and that's what keeps us from stopping bleeding. So when blood pools in these veins, we know that it has a higher risk of clotting, and that's why we like to evaluate for vein insufficiency, not just from a symptomatic perspective, but also risk. And so what we look at, what Carly looks at on ultrasound, because she's the ultrasonographer, is time. And so a vein should get the blood back up to the heart in a timely fashion. What is that threshold? A half a second. Blood should not pool in an area of a vein for more than half a second. We have some patients who come in who are very symptomatic, and they have 1 or 2 seconds of reflux or backflow of this blood until the pressure builds up enough to get it going forward. And we have some patients that have upwards of 7 seconds of pooling of blood. And 7 seconds is a long time. Usually when you cut yourself and you hold pressure on it for a few seconds, it starts to clot. So when we get upwards of 6 and 7 seconds, we get more concerned about the risk of blood clots. So the reason to treat these veins is symptomatic. So swelling, fatigue, heaviness, aching, night cramps is a big one, especially in the calves. A lot of people think that's an electrolyte imbalance, but for people that have venous insufficiency, oftentimes their night cramps are associated with vein disease, not necessarily electrolyte imbalance. So that's one of the things that we can evaluate on ultrasound. Restless legs is another one. If you have a hard time getting to sleep at night and your legs just feel like you need to be up dancing, that can be associated with vein insufficiency. Chronic wounds, if you bump your shin and it just flat out doesn't heal, it's been around for a couple weeks or a month and you feel like it should be gone, that pooling of the blood can increase healing time, and so that's why that wound won't go away. And then also reoccurrent infection of the skin, usually below the knees. The combination of all of these factors can cause reoccurrent skin infections.